Okay. Have you muted yourself, Jenny? So we got rid of that. Yep, sounds good. Okay, right, ready to go. Brilliant. Thank you, everyone. Looks like we've got a nice turnout. So thanks everyone for logging in. So I'm just going to give a quick update about where we are really at the moment with the treatments that we might offer for any children that we'd have here at Leeds. We've been like in a really fortunate position, actually. I can't really believe our luck that we haven't actually seen any serious cases of COVID-19 in children at the moment. So, but we have heard around the country that, that it is happening. So, you know, we have really been using this time to help prepare ourselves for how we would manage these patients. So I gave this presentation a couple of weeks ago. So I have put on in red like the bits of text that have changed. So I'll just try and highlight and concentrate on the bits that have changed. So this is just a recap about, haven't really seen anything to the contrary of this yet, but essentially showing the two phases of the disease, so the viral phase and then the inflammatory phase that we see afterwards, and the different types of treatment that we have available aimed at each phase of that. So that hasn't changed so far. In terms of recapping sort of treatment guidelines, so last time I focused a lot on the BPA-IIG guidance, and that contains essentially like the active treatment for the disease itself. But I actually missed out, and actually the people that developed that guideline actually missed out a lot of the respiratory support and general care of patients. And that's actually been contained within a guideline that's been shared from Alder Hey. So I've dropped that guideline into the folder and for people to look at as well. So the discussion nationally has been that these two guidelines should get amalgamated together under the banner of the Royal College of Paediatrics and Child Health. I wasn't able to log onto the call last night, so I haven't got an update this week, but my impression was that that was supposed to be getting made available. So I'll share that around once that's been done. So the Alder Hey guideline, you know, says a lot about like the respiratory support, what modes of oxygen delivery to use, that sort of thing, fluid management, and then the BPA-IIG guidance has all the sort of fancy treatments that we might offer. So I mentioned like this hasn't really changed already so far, but there was a discussion in the meeting last week about the use of antibiotics, and at the moment we are a bit unsure about the role of like atypical antimicrobials. So there was a discussion about the fact that patients should be treated with a macrolide if there is a suspicion that there might be a bacterial involvement as well. So that was something that was going to change in the guidance. I haven't checked to see whether it has come out yet. So the clinical scenario where we'd see that would be a patient who was admitted, say like to PICU, or admitted with sepsis and perhaps on ceftriaxone, and the fact that we should just make sure that we're covering sort of atypical. So I looked this morning and there was a patient on 47 and you could see that had happened, that didn't need respiratory support and was hopefully getting discharged again, but you could see that treatment had been added just to cover. So while they're waiting sort of like a positive test, and sort of if there's still any query about bacterial treatment, to think about extending the cover to atypicals. And then the other thing that came up was a big discussion about anticoagulation and the role of anticoagulation. So you may have seen there's a few papers come out now showing that patients with severe disease are likely to experience thromboembolism. So I believe like there is adult guidance out at the moment with sort of DVT prophylaxis and treatment in COVID, and that's something that we should bear in mind when we're treating any children. We know that there has to be a bit more of an assessment in terms of the age of the patient and perhaps any other conditions, but it was felt that it should be like actively thought about, that patients should have like a risk assessment, and that particularly if they've got raised inflammatory markers, and D-dimer as well would probably be something else we'd look at. If that was raised, then we would consider maybe prophylaxis or treatment. And that there was also discussion about the fact that might get continued like beyond so like a 6-week course. So we'd have to make sure that we were just checking what the decisions were in any treatment about how long, if we knew that up front, or if a patient was getting discharged from ICU or discharged from the hospital, about how long they'd want to continue that. So those were just a couple of things I picked up that I thought was interesting and not very sort of highlighted in the guidance previously. The BPA IIG guidance still hasn't changed, so we're still looking at assessing any patients in terms of severity. It's probably worth mentioning that mild to moderate cases are really not being offered anything else other than supportive care, and that we are seeing a few critical patients and severe nationally. And then this feeds into a little bit what we'll talk about the treatments we're offering at the moment in clinical trials, in terms of that's very much what the clinical trials are sort of broken down into as well. So you've got clinical trials that are trying to look at like mild disease, and then you've got clinical trials that are looking at more serious diseases. So this is a guide. This is a document that I've dropped into the folder as well. So this is a UK position statement on active clinical trials at the moment, which I thought was just a nice summary. So I'll talk through it just in case it's not very clear on your screen. Essentially, at the top here, it's saying about what sort of stage of disease you're at or where you are at. So moving from primary care all the way through to intensive care. And there's a few trials open at the moment that you've probably heard about that are looking at testing existing treatments or existing drugs that are available. So hydroxychloroquine, there's a study that you can get enrolled on in GP practices at the moment, the principal study. And then we've got the recovery study, which is for hospitalized patients that offers sort of antiviral and a few existing treatments as well. Recovery is getting expanded a little bit, so they're now going to include some immunomodulation treatments as well. And there's also rumours that it's going to get expanded down to cover children as well, but we haven't really heard anything else yet except for just being a rumour. The way that the recovery trial works, there will be some things to consider with that, so we just really need to wait and see, really. And we've had a bit of discussion already about the fact that recovery is a little bit a confusing trial because it's looking at antivirals as well as immunomodulatory treatments in separate arms. So whether that's going to change as well, because it doesn't really make sense to sort of decide that you're just going to treat one bit of the disease when actually there could be two sort of disease processes going on. So that's something that we've had a few conversations about at the moment, about how we'd want to manage patients, because at the moment, like our children would not fall into these trials. And we've then got a few sort of additional, so recovery is like the main like UK wide trial that's running at the moment. And then there's a few individual sponsored by drug company trials running at the moment. So there's a few remdesivir trials that we're unfortunately not centre for at the moment, so we don't have those available. And then there's also a couple other trials coming online. So I'm going to talk a bit about one of those that it looks like we might be getting set up for. So that's like the current status of play really at the moment. So we're still very limited in terms of any clinical trials that we can offer to children at the moment. So you may see at the bottom here, like the remdesivir compassionate access program. So that's sort of a sort of key thing that we've sorted out over the last couple of weeks. So disclaimer, same as last time, really, that none of these treatments are really based on anything much other than anecdotal case reports, and we're still updating things as things get published. So I shall update a little bit on what's happened in the last couple of weeks. So remdesivir does seem to be like the most promising antiviral, given its mechanism of action. Initially, there was just a few case reports that came out, but a couple of weeks, about 10 days ago, Gilead presented or published some of the data they had. So they published a case series of 60 patients, and this was a mixture of patients across Europe and the US and Japan that shed a little bit more light on this topic, but doesn't really tell us much about the effectiveness of it, but more about the safety in terms of actually it was quite well tolerated from the patients that received treatment. These things still stand, so it has very few interactions. It's available as an injection, so we can give it to severely ill people, which is good. And that with virals, that it's still thought the early treatment is the better. I've got treatment. I've put all the paperwork in the folder to help guide anyone that might need or handle any requests for this. So the paper didn't show too much really. It just showed about, as you can imagine, that patients improved after they had treatment. A few patients didn't. So you can't really take much more out of it than that. But they did have like a quite a wide or a good sort of adverse event follow-up, which shows there's still not really any adverse effects seen except for derangement of liver function test. So hot off the press today, we just had drugs and therapeutics at lunchtime today. So I can update you a little bit on the discussion about that. So we put together a sort of prospective application, given the fact that if we needed to get this treatment, it would be for like a critically unwell patient, and that time would be a factor. So drugs and therapeutics are happy that we can sort of access the program. Gilead have quite stringent criteria, so we believe that one of them at the moment is about the patient would have to be intubated, so that's a fairly limiting criteria. It's very unlikely we will see a patient that will qualify for that, but drugs and therapeutics are supportive. But due to the nature of the way and the liability that the trust has with managing compassionate access program, once we access it, we'll find out a bit more about the paperwork and the contracts and the consent form, but that's something that the consultant requesting it would have to work through along with our help to facilitate that. It does require like a sign off or approval by someone from the senior management, like trust management, to do with liability. So there almost still needs to be sort of approval from someone, but drugs and therapeutics are supportive and would help to gain approval for it once we wanted to access it. So I've dropped in the folder just a flow chart that I've written out, and this should just help to not only sort of guide the process, but also manage some expectations as well in terms of, and that's been reiterated to Sean O'Riordan was on the call today, as well as Valentina Leone as well, one of the rheumatologists. So, and we're very aware that there will be, time lags between initiating, accessing these drugs and actually getting hold of them. So I've put up the top of the form just a little bit about what the criteria was at the moment. A bit of a check in terms of making sure there's no clinical trials that we've missed, assessing the patient for severity, and then moving down into the practicalities of accessing the drug and getting it delivered. We've spoken to QC, who are happy that once we would access the program, we'd then talk to Gilead about getting like the certificate of analysis for that particular batch of product, and look about the logistics of actually getting the product like through the dispensary and onto the wards. That's something we've kind of opened up a channel at the moment, but we'll only know once we access it exactly what the particulars are going to be about that. So that process is in the folder for you to look at. Happy to answer any questions on that as well. There's not really anything to say about any other antivirals at all. Gleetra is still included in the recovery trial. I do wonder though, because of the fact that the liquid is unavailable at the moment, so even if the recovery trial will get open to children, it might not be available because they would probably need a weight-based dose. And if the liquid isn't available, then I can't see how that treatment would be available to a child to receive. So I haven't really got much else to say on that at the moment, but just it's not really available. There's no data come out since I last spoke. And again, I haven't really got anything to say about hydroxychloroquine at the moment as well either. That's just awaiting sort of ongoing results and things. So the bit I'll spend a bit more time talking about today is about immunomodulation. So this is trying to switch off the sort of hyperimmune condition that the patients get, and really talking a bit about the background to this, although I've still got quite a limited understanding of it at the moment. So, but the thing I think that's reassuring about this is more based on there's like a biological pathway associated with this. So the treatments that we'd be offering, it kind of makes more sense to me that we're actually, there's a plausible mechanism. I think like hydroxychloroquine is still quite questionable about what its actual mechanism of action is, whereas for some of the biologics and immunomodulation, actually there is a clear mechanism for it working. So what this slide is showing you is on the right hand side, these are sort of pathology slides taken from post-mortem examination, and this kind of reminds me of my days back in oncology and hematology about all the grand stains and looking at the cells that are present. That this is essentially showing that there is infiltration of like white blood cells, and they're causing damage to like the respiratory cells. So that's sort of that's been observed, in patients that have had COVID. And then what this case, or what this data on the left is showing is actually different biomarkers, and how that's associated with mortality. So the green bars are what the sort of results or the distribution is for patients that survived their COVID course, and then the orange bars are the distribution for patients that didn't do well and unfortunately died. So we can see it with like C-reactive protein, and interestingly, like with the interleukin-6, that patients that do worse actually have raised levels of this as well. So that again feeds into a narrative that if we try and target this, this may be associated with worse outcomes, and if we could perhaps try and target that, then that might lead to benefit for patients. So, and I think Sean at the Grand Round on Tuesday presented like a meta-analysis. So I think there must be a couple other trials that have highlighted these raised inflammatory markers as well. So in terms of interleukin-6, we have a monoclonal antibody available that targets that. And was trialed in China. I think from the initial first SARS outbreak, this was shown as well. So it was quite quick to utilize at this time. So there was some Chinese data which showed very promising. I'd say promising results. You've obviously got to take that with a bit of pinch of salt, but showed that patients improved that had it essentially. And then thankfully, or very helpfully, Valentina has been offering us some commentary on what's happening in Italy at the moment. So there has been widespread use of tocilizumab in Italy due to a large compassionate access scheme that was made available to the country. So we're still waiting for these case reports to come out, but there was some data leaked in a meeting that was discussed and that got through to the press. Essentially, I suppose, similar to what the Chinese data showed, that about 50%, about half of patients got better, about half stayed the same, and about half got worse. So still really, it looks promising, but we can't really say for sure whether, what kind of positive bias is in these results. But certainly it looks like much more dramatic changes as opposed to some of the other treatments we've seen that perhaps a bit more, certainly with the Calitra data, it was showing that the benefits were really modest. They weren't really seeing much different between the control arms and not. We've also got a bit of anecdotal evidence through some other centres using it. So at Drugs and Therapeutics, we were talking about how we'd access this, and that's going to be the next bit of work over the next week or so. Is trying to get some perspective things together about how we'd manage any requests for that at the moment. So I'll be updating you all on that in the next week or so. There is also another interleukin antagonist as well, which is anakinra. I don't really have too much history of using this at all, but having discussed it with Valentina, this is perhaps slightly more selective from what I understand in terms of its place in the pathway, the immune system pathway. So she was explaining to me that actually, if we think that there's a bacterial infection underneath the viral infection, that it may be preferable to use anakinra, because this is very sort of just, she was explaining, it's just clinician and our professional sort of opinion about that, but that might be favourable, although there's no evidence to sort of prove that one way or the other, but that might be a treatment that we look at being made of it. It depends what's available as well, so we're going to have to factor all those things in as well. So those are sort of the main treatments that have been used at the moment for severe disease. But I also just need to give a quick update that we've successfully been able to become a centre for a trial, which is another immunomodulator called roxolonitib, which is a JAK inhibitor. So this is involved in the process I've written out here for those that are interested. That helps in the sort of blood cell production and immune response. So this is a company that I think that have shown they're hopeful that there may be a role for their drug in this disease. So they've set up a reasonably sized study so they're just looking at mild disease, so they're interested in whether you could try and shut off the process beforehand, but it does look like we're going to open this trial up, and it will include patients over 12 years of age. So although presumably most of the recruitment is going to come through adults, and the chief investigator for this, for our site at Leeds, is an adult clinician, so they presumably would be doing most of the recruitment, but it's something to bear in mind, I suppose, really. It's fairly limited inclusion criteria because the patient has to not be intubated, so I do think it's probably unlikely that we would have that to use, but that just gives an idea in terms of a flavour of some of the clinical trials that are coming online. but they might be fairly restrictive depending on sort of what formulations are available and what like the inclusion criteria are going to be. There is some information in the protocol about how to administer if you've got feeding tubes, so I've just popped that on there as well. So that's it for this week. I've dropped all that information I've spoken about in the folder. So if anyone's got any questions, I'm just going to pause the recording now, and then if people want to put it in the chat, or I shall unmute you if I've